Okay, so we're going to go ahead and get started. So welcome everyone. Thank you so much for joining us for our of our Future M.D.s in STEM summer program. We're very excited to kickstart what is our sixth program since we started in 2020. So my name is Davina. I'm sure I've met a lot of you at this point, but you've probably seen me in your email inboxes and also on Slack. I'm the founder and chief executive officer here, and I'm very excited that you chose to spend part of your summer with us. And now I'll let Ahmad introduce himself.
Hi everyone, I'm Ahmad. I am the executive director here at Mest Empowered. About 5 years ago, I was in y'all's shoes as a participant, joining in, very eager to learn, very excited about the program. I'm really excited that you guys are participating in this summer's program. My number one piece of advice is stay curious, ask questions, and be attentive to all programming. So I'll hand it off to Rorik.
Hello, everyone. It's nice to see you all. I saw you all on Friday at orientation. Um, kind of just like Ahmad, I think 4 years ago I was in y'all's shoes, the year after Ahmad, and I was part of the program, and now I'm here helping run it. And I am the person to talk to if you have any technical issues or questions about certificates or things like that. So please message me on Slack if you guys have any issues whatsoever. I will get back to you as soon as I can. But today we are going to be talking about emergency medicine, which is something I'm very passionate about, and I've had the opportunity to volunteer in an ambulance. And so that is what we're going to be talking about today for our workshop. So let me put this in present mode. Awesome. Okay, we're going to get started then. First, just a quick reminder to ensure that your mic is on mute so that we can get through this smoothly. Also, if you are on Zoom and you're not using your full first and last name that you want on your certificate as your Zoom name, please change that. It's really important for us to be able to track that you guys are doing that, so that when it comes time to give you your certificate, that there are no issues. And like I said, if you have any issues with polls or attendance, just message me on Slack, please. Not on email, not on Zoom, on Slack. Um, so first off, if you guys want to put in the chat quickly, how you guys are feeling on a scale of 1 to 10. This morning for the international session, I was or 1 to 9, sorry. As the cats on the screen. This morning when I was running the international session, I was definitely a 1. I was a sleepy cat. To now I'm feeling awake. I went to work. I'm back. I'm feeling more like, I don't know, maybe a 6. I'm chilling. But I hope you guys are all doing well. And then in a second, we're gonna disable the chat just to so you guys can pay attention to what we're talking about until we get to the interactive portion. If you guys have a question about something we go over and you want to ask me about it, just write it down or write it on Slack, and we'll get to them later. I just don't want to pause and go in between each of the different slides. Okay, cool. All right, so we're gonna get started on emergency first aid and CPRC. So the first thing I'll say is that anything we go over in the slides today may be slightly different if you have CPR or ambulance experience. This is when I was trained, I think 2 and a bit years ago now, and I haven't been working on an ambulance in about a year and a half. So it's been some time, so things might have changed, and also in different countries there are different protocols, so it might be slightly different. But this stuff is all stuff that is accurate to my knowledge. And, if you do it, it may not be the at most perfect protocol, but it'll be something that'll, help people. So first off, really quick background. When you're doing a CPR course, there's the level A, the level C, and the BLS. So BLS stands for basic life support. And then the different levels are just about if you're doing adult only or if you're doing baby and child CPR as well. And the same goes for first aid and standard first aid. So this goes for basic life support and then adult and total. So when CPRC just includes all adult, baby, um and all and children CPR, and then A is only for adults. So the very first things when you are doing CPR or when you're finding some sort of person out in as a bystander or if you're on ambulance are the 3 C's. So the three C's are check, call, and care. So you want to check the scene, check the area, and check the patient, and then you want to call. This is typically 911 who you're calling. If you are 911, in this case, you don't have to call anyone. And then care, which is providing treatment. So today we're going to go through all the different types of giving CPR and basic life support, both from a bystander perspective at some points, and then also from as if you're on the ambulance in some points. So when you're checking the scene in the area, the first thing you want to do is make sure that there's no hazards to you or the people in the area that need treatment. There's no further hazards to them. So this includes fire, gas, glass, and wires. Wires being electrical. And normally people will say no fires, no wires, no gas, no glass. Okay, you're good to go. If there is gas, especially if there's like you see a bunch of people lying down, passed out, it could be because of gas. You definitely shouldn't go in. You should let the fire department deal with that first, and then you'll be able to go in. Also, if you see any firearms or people causing harm to each other, knives, things like that, do not engage with them. Wait for the police to get there and then give critical treatment when necessary. This should only take 1, 2, 3 seconds to check the area. Most of the time, there's nothing. Sometimes there is, but you want to just do this check really quick because you don't want the people that potentially need care to wait too long. All right. Um, if you see a knife in your patient's chest, this also goes for any other blunt object. So it could be like a pole, an arrow, anything like this. Do not remove it. If you are not 911 and you're a bystander, call 911. If you are 911, definitely stabilize the wound and don't pull it out. The knife or other object in the body is actually keeping the blood inside the body and preventing the person from bleeding out. Because if you lose too much blood, then oxygenated blood can't go to your brain, can't go to your critical organs like your heart, and your body starts to die. So keeping that knife while it's painful in the body actually is being working like a plug in a bottle and keeping all of that blood still inside the body, and it's really important. The other thing is if your patient or person on on the side of the road, wherever you are, is semi-conscious and they look like they're trying to fall asleep, try to keep them engaged, ask them questions, and keep them awake. If they're awake, that's a good sign. That means they're getting enough oxygen. So you want to try and keep them awake. You also then can ask them questions about how their symptoms are, and if it's getting worse, well, you can't ask someone who's passed out. The other thing is if there's babies and parents in an area, check the babies first. Babies are a lot more fragile. Their bodies are smaller. They're not developed, so they can have damage much easier. So check babies first, and then parents or guardians. Next, check the patient. The three things when first checking a patient, especially one that is critically injured, is the ABCs. This stands for airways, breathing, and circulation. So is their airway open? Are they able to breathe? Are their lungs working? Are they breathing? And then circulation, do they have a pulse? So we're going to look at this from the scenario one, which is the conscious patient first, and then we'll look at it from the unconscious patient. So examining the scene, which we just talked about, is the scene safe? Yes, under this scenario, all these things, there's none of them. We're good. We can go. Then the next thing you want to do is introduce yourself. If you see someone or you're called to someone, you want to introduce yourself. Hi, I'm Rourke. You want to be personable, and you also want to tell them who you are. You can say, "Hey, I just saw you. I saw you get hurt. I have some CPR training. Like, what are your symptoms? How are you feeling?" If you're a first aid responder, you say, "Hey, I'm an EMT. Let's check you out. How are you feeling? What happened?" That kind of thing. And then you also want to ask for consent if the patient is conscious. It's really important to ask for consent because, especially with non-critical patients, they might just not want treatment. And so you see someone get hit by a car and they refuse treatment, and well, there's nothing you can do legally. If they say no and you're a bystander, that's when you call 911 and you let the cops and the ambulance and the EMTs deal with it. If you are 911 and you're on the ambulance and this happens and they say no, then you typically talk to the cops and see if they can convince them. And if you can't, sometimes you just have to let them go, which is unfortunate. The next thing, after you've done all that, you've gained consent, you want to start helping someone and you don't really want to stop until EMS arrives. Again, if you are EMS, then you just keep going until you get them to the hospital. If your person is conscious, um, then and you're doing CPR, then there's normally pretty good. Once they're conscious, you probably don't have to do CPR because they're going to start breathing on their own. But if they're conscious when you get there and they stop being conscious, then their heart stops, they stop breathing, then you have to do it until they get their breath back. If you're tired, typically we only do each person does CPR for about 2 minutes and then you swap. That's why ambulances always have multiple people on them. Also, police are typically CPR trained in case you have to do it for a while. But it's important that if you feel tired and have other people nearby, even if you're a bystander, you can coach someone through doing CPR. And if you're doing it for like 5, 10 minutes, it's really tiring when you actually have to do it. It doesn't seem it, but it's really tiring. So it's important to be able to rest yourself because the longer you do it, the more tired you get, the less effective you're being at it. And so if you want a chance to get that person back, you definitely want to swap out. And even if you have to coach someone through doing it for the first time. And then also stop if the scene becomes unsafe. Like we said, if you check the scene, it looked all good. And then, part of the building starts collapsing or something next door, or like an electrical wire, you find an electrical wire, or something breaks and it becomes unsafe, then you would have to stop and, either try and get yourself and the person to safety or just yourself if you can't get the other person as well. So again, when arriving at the scene, you want to try and help children first. We talked about that before, but it's important to also consider who's critically wounded the most. If you check the children and they just have like scrapes and wounds, and you see some adults with serious conditions, then you would definitely want to check them and go immediately over to them. So if we have a conscious patient and you're arriving and you get there, the first thing you want to do is ask the sample questions. The sample questions are 6 questions that kind of give you all the background information that you need to assess what's going on with a person and in a situation. So S being signs and symptoms, A being allergies, M being medication, P being past medical history, L being last intake, which means last time they ate or drank, and then events. If they remember what happened, them being able to say, I don't remember what happened is info in and of itself. So all these things will help you determine what possibly is what the symptoms are coming from and potential treatment options. And then scenario 2, if you have an unconscious patient, like I said before, you would call 911 if you're a bystander, and if you are 911, you would just start. But you'd have implied consent. What implied consent means is through the law in most countries, I'm not sure it is in every country, but definitely in North America and most countries around the world, you have something called the Good Samaritan Law. This protects civilians and EMS services from being sued by patients that are unconscious and receive treatment. And then afterwards, they're like, I didn't want that person giving me treatment. I'm going to sue you. But the Good Samaritan Law is that you're providing treatment to someone who is in need. And so you're covered legally. So you definitely want to start if someone is unconscious. If you can, you want to just wake them up and find out more information. So like we said, the ABCs, airway, breathing, circulation. If you see that the patient is unconscious, first thing you do, wake them up and then immediately start looking at the ABCs. The way to wake them up is first, just start saying, hey, you start yelling at them. You don't have to be mean yelling, just like, hey, how are you? Are you okay? Wake up, etc. You can also clap at their ears, tap them on the shoulder. You can also pinch them in this area right here, which is the trap muscle. If you pinch really hard, it hurts a lot, and it is really good at waking up unconscious people. I've done it a few times, and it almost always works. Um, and we use this shoulder tapping trap pinching method because it stimulates muscle contraction in the neck, which is right next to the brain, and it helps wake them up. The tapping shoulder is just the lighter version of the trap pinch. So in this case, if the person doesn't wake up, you want to start weaponizing the people around you to your advantage. If you are a civilian, you don't want to spend time calling 911 when you could be helping someone. So if someone else is nearby, you say, "Hey, can you call 911? Hey, can you find the nearest defibrillator and bring it over here in case we need it?" So you want to start using the people around you as your makeshift team to help the person in need. If there's no one around you, you should call 911, put it on speaker, and then just start working and trying to help them and do CPR immediately if they need it. So here we tilt their chin back. the first thing to tilt their chin back is because it opens up this airway. If you're like this, it can close the airway and make it harder to breathe. And also, if there's food or anything else in their mouth, if they've been vomiting, potentially from a seizure, before being unconscious, then it could be trapped in there. So tilting up the neck opens this airway, which is the A and ABCs. Then you want to continue with the ABCs and look at breathing. So you can put your ear like right next to their mouth and feel and hear if they're breathing. And then also you can look at their chest if it rises and falls with each breath. If they're wearing heavy clothing, you can take off their clothing. If they're wearing a jacket or something, I wouldn't, tear off someone's clothes naked if you're just a civilian and they're unconscious as the first thing you would do. But when EMS gets there, if you are EMS, they might determine that tearing off the clothing is something that is required. Especially if you're going to end up needing to use a defibrillator, then you do need to. Um, so after you've done all this, let's say you don't have a defibrillator. If you have a defibrillator, defibrillators are pretty easy to use. They all have instructions on them, and some of them now even have voice instructions. So you'll click a button that's like start, and it'll be like put this node on this part of the body. Put the other node on this part of the body. All right, 5, 4, 3, 2, 1, and then it'll just go and it'll just start working. And then it'll tell you also to continue compressions after. So those are great. And if the person is breathing and you've got them back, then you would roll them on their side like this. The examples are down here. And you would say, okay, this is the recovery position. You'd roll them over as the person on the left or the picture on the left is showing. And then the final position would be the picture on the right. Basically, just this supports the head. This also prevents them from choking on anything. If they accidentally throw up in their sleep, then the vomit will just come out on the side and won't get lodged in their airway, so they'll be able to breathe. And then their knee would stop them from rolling over. So the recovery position is pretty good. It's used both for unconscious patients that are coming back from CPR. It's also used for post-seizure patients, things like that. The other thing you want to do is continue checking their ABCs before ambulance gets there if you're a bystander. And if you are on the ambulance at this point, you're probably just waiting to transfer them. But I would continue checking their ABCs every minute or two, just in case that if something stops working, you want to make sure that you're ready to go if you need to again. So unconscious and breathing. In this case, there are a bunch of different causes. It could be diabetes, so low or high blood sugar causes them to pass out. Normally, it's low that causes them to pass out, but sometimes it can also be high. Dehydration, so lack of drinking water. Weak stomach, so sometimes when you see other people vomit or someone sees like blood or something like that, some people are known to pass out. And then also from seizures, which I mentioned. Down here on the bottom is a picture on the left of a blood sugar monitor. So this you put a little bit of blood on the tab at the bottom, and then it tells you how much sugar the person has. 5.8 is pretty normal. Normally it's around 6, so that's good. And then this is a blood pressure cuff on the right. Now, if someone was not breathing, you've done all this stuff, you've checked the ABCs and they're not breathing, then you would do CPR. So these are kind of the steps towards doing CPR and how you're doing them. So first of all, if you have PPE, if you're on the ambulance, then you should use it always to just prevent infections. But if you're a bystander, you may not have access to this. So there's nothing you can really do about that. You wouldn't use it. In adults, you want to go about 5 centimeters deep in compressions and you have your hands interlocked like this. Some people like it to have their fingers out. Some people like to have their finger like inside in between their other fingers like this. I like it like this. I just find it's more comfortable. You want to be comfortable when you're giving CPR because it can be tiring. And you put it over their sternum, which is like this area right here. And you would do 30 compressions and then followed by 2 rescue breaths. But these days, rescue breaths are not like in the movies where it's mouth to mouth. We actually have pumps for this now. And when you're giving CPR, you want to keep your elbows nice and locked and push down with your shoulders and back, and then push back up. You don't want to push with your arms. You want to be nice and still and firm and still and push in this 5 centimeters deep. And then for children, you do a shorter distance. It's normally about 3 centimeters deep or one third the chest depth. With children, it depends on their development. A 8-year-old could be much, like vary in size significantly. Same with a 15-year-old. So you don't really know. It's kind of best judgment when you see the person. And similarly, 30 compressions followed by 2 rescue breaths. And then often if you have a defibrillator, it would be 30 compressions, 2 rescue breaths, check the defibrillator, see if it says to give a shock, and then it will tell you whether or not you need to give a shock or not. And then babies use this 2 finger compression. You can either hold the baby here and push down with 2 fingers like this, or you can hold the baby kind of like with both hands behind and use your 2 thumbs to push. And I like this method. I've only ever had to use it in practice, but I like this method for comfort. And then you'd push like 2 centimeters deep or so. And with all of these doing all these compression methods, being about 100 to 120 compressions per minute, lots of people use like metronomes, like which is just an app on your phone that would just tick at 100 to 120 compressions per minute. And some people like to use songs like "Staying Alive" is a famous one that is just at that many beats per minute, so you can follow along. So these are the equipment that we use when doing CPR. So on here is the Ambu pump. This is just the brand of the pump. Different people have different brands, but you can see on the bottom left, that's the mask that goes under or that goes on the mouth and covers the nose. This bag here is what you push with your hand and sends air in and out. And then on the tube on the right would be connected to a bag or oxygen tank, depending on the scenario. This is defibrillator. So on the left, you can see the nodes that go on the body. You see how it already shows what area of the body the node's supposed to go on. And then you can see it has also a speaker because it's going to tell you information if it needs a shock or if it's going to count down the shock so you can take your hands off the patient. And then here's an airway. This is an object used to ensure that the airway stays open. And often it's used before putting in the ambu pump. You put in the airway and it goes in the mouth and then twisted and pushed down into the throat. Some other objects are suction. Suction is normally used when the patient vomits, and then you'd suck up all the different vomit from their mouth to help keep the airway open. And then catheters, which aren't actually used for typical catheter purposes normally, they're normally just what's attached to the oxygen tank, and then you attach the other side of the catheter to the mask um, so that you can give a patient oxygen on an ambulance. So really quickly, if everyone wants to take maybe about a minute and practice using CPR on a pillow if you have one nearby, or another object that might be nearby that's kind of soft that you can, push 3 to 5 centimeters into. This is a good time to just take a second, see if you can practice it for yourself, um, and see how that goes. So I'm going to leave these instructions up here. I'm just going to pull up the chat so I can see if anyone has any things. Awesome. And then you guys can practice for about a minute.
Work. I had someone ask what is the best tempo based on age. So should they do 120 for children and 105 for adults?
The tempo's the same. The tempo's the same for all. It's kind of hard to get exactly like a number between 100 and 120, so that's just the range. But there isn't really a difference between adults and children for pace because the heart pumps at the same rate for adults and children. It's just because it's proportional to the scale of the size. So even though um, the child might pump this, it might be smaller, they don't have as much body to pump blood to. So the rate's still the same, and their heart is smaller. So it's just scales with their body. So the timing might not change. For really little babies, it might be slightly faster just because they're still developing. But other than that, there isn't really a difference. But good question. Okay, so hopefully you've tried it. If you haven't, you can also try it after, and these are the instructions, and you can look at the slideshow later. But we're going to continue because we have some other stuff to cover before we get to some practice examples. So we're going to quickly cover a few other things besides CPR, just in emergency medicine in general. And one of them is going to be choking. So the main difference between a partial choke and a complete choke is how much of the epiglottis is open. So when someone is partially choking, only part of their epiglottis is plugged. The main difference that you can tell when you're looking at symptoms is they can make noise. They can cough, they can maybe whisper things to you. And so they'll still be able to talk to some degree. And what you can do is you can talk to them, you can ask them, they'll normally say or cough, and kind of like tell you what's going on. And then if needed, you can do abdominal thrusts at the end if it becomes a complete choking. So this image of the lady and the guy on the right here shows her giving him abdominal thrust. This would only be done in a partial choke, in a full choke. In a partial choke, you would want to encourage your patient to keep coughing and keep coughing as hard as possible. So that way the air from inside their stomach and their lungs will push the the object that's blocking the epiglottis out, using that force from the coughing. If it becomes a partial choke, or complete choke, sorry, the epiglottis is completely stuck. An adult will have 2 to 3 minutes without breathing before they go unconscious, and potentially have brain damage. Children or babies, it'll be even less. And then you want to do abdominal thrusts as fast as possible, and for someone to call 911 if abdominal thrusts are not working, then you want 911 to be there as fast as possible as well. So what it would be like is like in the image, patient bent slightly forward. You'd put one of your legs in front of theirs. So this one's kind of doing it. It's not the best image for legs, but you put your leg in front of theirs, and then you do these abdominal or chest thrusts. So it's like a fist. You wrap it around your thumb, and then you go up and in underneath the sternum, like we saw before. So you go up and in, and you'd put force behind it to try and push all the air from their abdomen and their lungs out, and that would hopefully dislodge whatever they're choking on. So, I'm not gonna actually get one of you to answer this, but we'll think about for a second why we might need abdominal and chest thrusts. Just quickly, if people in the chat want to take a quick guess, I'll take it if someone knows. If not, that's okay too. You guys can guess. Manual force. No, we don't need it for manual force. Manual force, the abdominal thrust is better. Just period. Abdominal thrust is the best way to get it going, to get something out because you can get more force onto the lungs. Okay, yes, pregnant person is one of the reasons. That's a great reason. So I'm going to show the other reasons, and the other reason, the main reason, is for people in wheelchairs. So pregnant individuals, you can't push on their abdomen, and people in wheelchairs, it's really hard to get around the wheelchair, or if they're in crutches, things like that. So you use the chest thrust. The only difference is the location, so you just do the thrust a little bit higher up, but the chest thrusts aren't as effective, which is why you only do them in these niche scenarios. So here again, some other special cases might be height differences. So if someone is way taller than you, you might get them to kneel, or if you're way taller than them, you might kneel. And then if you're at a house or an apartment and you need help, you can call 911, call a neighbor, pull the fire alarm, try and get other people's attention. The main difference in children and babies, and this would be for young children, probably like under 3, maybe under 2 even, depending on the size, is you'd use this method called smoking the baby. It's where you place your fingers around the chin and you kind of like where the baby's face would be. You use these fingers to open their mouth. You tilt the baby face down at about a 45-degree angle, and you hit their back to try and push the whatever they're choking on out of their mouth. And you do this 5 times, and then typically, if it's not working, you'd have to then flip the baby over and try and give the baby CPR because babies can't last without oxygen very long. So you'd have to do CPR to try and keep the heart going as well while you're doing this. So you do 5 back blows, and then you turn the baby over and you do 5 chest thrusts CPR style, and then you'd repeat and do 5 back blows again until you get the thing dislodged. I do have a quick video that hopefully works, and it shows this exact method. So hopefully you all can see it. So this example is pretty good. But the one problem with this example is they're not holding the mouth open, which is definitely something you want to do to make sure that the whatever object is in there actually gets out, versus them just swallow it again by accident. But otherwise, this example is really good. This is exactly how you want to do the back slaps, and then after doing this 5 times, if it doesn't work, you would do chest compressions. Cool. So I hope that example worked for everyone, and it was good because I can't see my chat right now. Um, but I'm sure Davina would have told me if it didn't. So there's a YouTube video. Um, Strokes and heart attacks, we're going to go through quickly. So strokes are caused by lack of blood in the brain, and heart attacks are caused by um, typically issues with the muscle around the heart as well. So they can happen in a few different ways. Ischemic means lack of blood flow, and hemorrhagic means excessive bleeding. So if there's bleeding in the brain and blood just keeps flowing to it, and ischemic means if there's a lack of blood flow. So typically the symptoms includes trouble speaking, vision, motor functions, weakness, numbness, inability to walk, all those kinds of things. And the way to respond to it is using the FAST criteria, which is face, arm, speech, and time. Face means ask them to smile because their smile will droop on one side. It'll just won't work. Half their face typically goes numb. Arm, ask them to hold their arms out like this, and one of them will just drop if that could be one of the symptoms due to numbness. Their speech could be slurred, and then T for time isn't actually a symptom, but it's just something to note. You always want to ask how long this has been happening for. If you see anyone with these FAST criteria, you want to call 911 immediately. And then also, if the bleeding's external, so they have a gash in their head, you want to try and stop the bleeding if possible. So heart attacks typically happen because of either one or two things. One, a blockage of the artery that supports blood to the heart, or two, an issue with the heart tissue itself. These are some of the symptoms. Um, the main response, honestly, to treat it is just call 911 as fast as possible. And then also on route, you can take 2 ASA tablets, which is also known as aspirin, which is a blood thinner, so it helps get blood back to the heart if the artery blockage maybe isn't completely blocked, just mostly blocked. Bleeding. So quickly, bandages. If you have a small gash or something, you could just bandage it, put some pressure on it. If the wound is really large, let's say you have a huge gash down by the wrist, let's say, you'd want to potentially use a tourniquet. So tourniquets are just essentially really tight ties that are made of normally rubber, but you can also make makeshift ones out of cloth and things like that to to stop bleeding, to prevent bleeding so that someone doesn't bleed out when they have a big wound. You want to put them about 3 centimeters above the joint at minimum, because the joints are flexible and so it might not stay fit if it's not on the joint. If it's on the joint, sorry. And then 5 to 10 centimeters above the wound so that there's ample time for the blood flow to be cut off. And so you tie them tight and then it stops people from bleeding out. Allergies. Allergies are pretty common. These are some of the symptoms on the left here. Common ones are like peanuts or fish. Um, they basically are Allergens are basically things that trick your immune system into thinking they are attacking it. And then your immune system tries to fight it by doing all these different things, and you get all these symptoms. Um, and so what ends up happening is increased heart rate, and then your throat starts tightening potentially, and then that can stop you from being able to breathe. So normally the main treatment is an EpiPen or epinephrine, and this is adrenaline that will prevent your throat from tightening because it loosens the muscle. Adrenaline loosens the muscle, so it will prevent it from constricting. The only thing when giving an EpiPen is the nice little saying, which is blue to the sky, orange to the thigh. Um, that means you remove the blue side, you face it up, and the orange part goes into the thigh when you push it down. You want to use the outer thigh when you push it in because if you put it on the inner thigh, then it can go directly into the artery and potentially stop someone's heart by going too fast. Um, so you want to put in the outer thigh so that it doesn't go directly into an artery and it slowly disperses into the system. Well, not slowly, but not as quick. And then you want to rub the area for a few seconds afterwards to improve circulation. Cool. Some rapid fire other medical emergencies include nosebleeds, which you never want to tilt your head up because then you might choke on your own blood, which is not good. So always tilt your head down. Knocked out teeth, which can be put in milk or saliva to help retain it and then put back in with a dentist. Sprains and bone infections, which use rest, ice, compression, and elevate method when you're resting. Diabetic emergencies, which we kind of talked about before. Pulmonary edema, which is liquid in the lungs, asthma, which is a um, breathing condition that prevents you from being able to breathe when you do exercise typically or when your heart rate goes up. So normally there are steroid inhalers which help combat that, and then wounds, which we kind of just covered with bleeding, but these are the different types of wounds and things you shouldn't do. Like if you have a chemical burn, a liquid chemical burn, you should wash your hands and remove your clothes, but if you have a dry one, you should not wash it because it could spread. Okay. I know that was probably quite a bit for not that much time because we're covering a lot of things in a short period of time because we only get one day for this. But we have some practice scenarios, which I think are the most fun way to actually learn this. So I'm gonna go through them with you guys. So if people want to raise their hands and use that function, Davina will call on you if to get an answer, and then other people, if you don't feel comfortable sharing or raise or unmuting, you can just put your answers in the chat, and I will try and read them as we go. So our very first practice scenario is, oh, and pardon me, all of these are going to be from the perspective of you as an EMT on an ambulance. So if you were on an ambulance and you got a call and this is all the information you got, this is what you're going to do. So the background information for the first scenario is an adult that's 32 calls complaining about chest pain. After arriving, you see the patient is anxious and sweating. What is the first thing that you would do?
I have someone with their hand up, Amina.
You would first inspect your surroundings and then like introduce yourself, right?
Yep, that's exactly what you would do first. So I wanted someone to say that the first time, but going forward in the rest of the scenarios, we're just going to assume that you're going to introduce yourself, so that we don't have to have someone repeat it every single time. But yes, that's exactly what you would do the very first time. When you're introducing your, when you get to a call, you'd introduce yourself and you would say, "Hi, this is me. I'm this person," and then you would ask for consent and check the area. Okay. The next thing, what is the next thing you might do as well? Okay, I'm just looking in the chat for this one. I'm seeing ask sample, do the ABCs, etc. So ask for medication, heart monitor. Okay, lots of good answers. Um, so here we would ask sample. The reason we wouldn't do the ABCs immediately is because we know this patient is awake. So if we see them anxious and sweating and awake, we know that they're breathing. And if they're talking, if they can talk to us, then we know that they're going to be okay for the next, few seconds at the minimum. So let's try and get some more information before we immediately go into are they breathing? Because we know they're breathing if they're awake. So you ask the patient the sample questions. What you get from them is that they're experiencing some chest pain, and it's on their left side. So their left side, it hurts over here. What do you guys think they might be experiencing? Davina, do we have any hands raised?
Yes. I'm gonna go
Okay,
in the order of who raised their hands that's new. So we have Vardan.
It should be a heart attack.
cool. I see lots of people in the chat saying it. Yes. An MI, a myocardial infarction, also known as a heart attack. That is exactly what is happening in this situation. And the key differentiation between that and a stroke is what? What do people think? Do people remember what the key differentiator between because there's lots of similar symptoms between heart attack and a stroke. So does anyone remember why we wouldn't think this is a stroke?
I have some people with hands up as well, if
Yep.
you call on
Just
them.
keep calling people.
Yeah.
I'm gonna read the chat
I have
while you do it,
Otis.
but just keep calling people.
Yeah, Otis and then Jacqueline.
Okay, the person isn't nauseous. They're speaking regularly. They can articulate themselves. Stuff like that.
Okay. Um,
Okay.
Jacqueline, did you want to add anything to that potentially?
I think a stroke is more like a lack of blood or something, or like it has something to do with like the blood inside versus a heart attack is just like an artery block.
Okay. So both of those answers are mostly correct. You guys both got like 90% of it. So Jacqueline's answer is like very accurate on the physiology and what is happening, which is why they are different, yes. From the symptom perspective, Otis was correct, except for the nauseous part. The nauseous part could be either, but the speaking is the main thing. So I see a lot of people in chat saying the fast mnemonic, which is right. There's none of the fast symptoms, and the key thing in this is the radiating pain from the chest area to the left side, which is very common in heart attacks. So that's kind of where we differentiate from a stroke from a symptomatic perspective. And then yes, from a physiological perspective, it has to do with blood in the brain versus an artery blockage. So we're going to move on to scenario 2. Um, so in this case, you get called to a school. This is from because of a school nurse. Um, and the child is feeling really lightheaded and confused. So first the nurse, we're going to pretend the nurse is telling us this, but we get called here and the nurse first asks the child if they've eaten, drank water today, and they say yes. The child continues to get worse throughout the day, dizziness and fatigue until they go unconscious. And then the nurse calls for an ambulance. So at this point, we show up. What do we think might be some of the causes for this? Let's just spitball a couple ideas.
I have Adam with their hand raised.
Yeah, Adam, what do you think a few
Usually
ideas might
this
be?
would be low blood sugar in most cases.
Okay.
However, I would also check their blood pressure because usually they might have low blood pressure. In the case that both of them were perfectly fine, I'll definitely try and check their heart rate as my third option. And I really believe that
Okay.
these will just like cover everything, as it's most probably going to be their blood sugar or their blood pressure that has something wrong with it.
Okay.
Indicate that they were still feeling nauseous. I just ask them to lie down, and maybe I'll even check their breathing because sometimes it just might be like a panic attack or an asthma like attack that might be causing their nausea or fatigue.
Okay. Great answers, super in depth. The one thing I'm seeing from some other people in the chat that is also correct is dehydration. Could be another reason. If there's severe dehydration, it could be all of these symptoms as well. And then I'm seeing some people say allergic, and in some cases it might be allergic as well. The main reason to probably rule out allergy in this situation um, is the length of time. Allergies normally happen pretty quickly after exposure. So if it happens over a full day, it might not be it probably wouldn't be an allergy. So when we get there, the child is the same information as above. They go unconscious. They are breathing a bit heavy, and their pulse is in the normal range. So what would be the next thing you guys would do?
I have Samira with their hand up. I think they're unmuted, but I can't hear them. So we'll go to Moaz.
Can we check ABCs or check blood sugar?
Okay. Yeah. So in this case, we've already checked the ABCs, but blood sugar is a good thing to check. So here, breathing is a bit heavy, so that's the B. We know A is good because they are breathing. And then you also check their pulse, and it's in a normal range. So I'm seeing lots of people say blood sugar. I'm also seeing some people say panic attacks, which definitely is a reason to feel for this to happen these days. It's definitely more common now. Um, Typically they wouldn't last this long is the main other thing. Like allergies, it wouldn't be this long of a time range with something like a panic attack. So I saw lots of people say blood sugar test. Absolutely right for this scenario. So blood sugar test is the next thing we're going to do. The test comes back at 2,500 milligrams per dilution, which is extremely high. What do you guys think might have happened, and what should we do for treating these symptoms now that we've kind of figured out what is wrong?
I have someone with their hand raised, Jim Doodoo. And again, please feel free to correct me if I mispronounce your names at any point.
I think he's like a patient with diabetes 1 and has a lack of insulin. We should give him an insulin shot.
All right. I'm seeing other people in the chat say this too, and that is perfect answer. In this case, we know after we've given insulin that the child forgot to take their insulin that day. And then if the symptoms are really bad, we would take them to the hospital. Mostly at this point, if they've gone unconscious, the symptoms are progressed enough that we would take them to the hospital. So great job. That is exactly what we would do. Okay, scenario 3. Oh, I apologize, guys. Okay, we're gonna just do scenario 3 because it's all on one slide, which is an accident. But in this case, read this slide, and then we're gonna see the next person remembers how to smoke the baby, not choke the baby. And I'll take a hand when anyone's ready if they want to tell me how to smoke the baby. Yes, I saw Nora first. You want to describe how to smoke the baby?
Sure, yeah. I'm gonna use this water bottle as an example.
Oh,
This
perfect.
is like the baby's head. So
I
you're
love
gonna
a prompt.
so you're gonna turn it so that the baby is facing downwards, and then you're gonna have the baby's mouth open, pretend like the cap is open, and then take your hand and hit it at the upper back, I think, upper sim. Hit it 1, 2, 3, 4, 5, and then check if it's the item that's choking the baby has fallen out.
Okay. And if the item hasn't fallen out and the baby is not breathing, what would you do next?
That's when you start CPR, and you can use it with the 2-finger method if the baby's tiny enough. Hard compressions on the chest.
Okay, exactly. So you would do that, and then you would go back to smoking the baby again and back and forth until it's done. So that's exactly right. That's exactly how you would do that. So great job, Nora. Thank you for especially with the water ball. Perfect. So yeah, that's exactly how you would smoke the baby. And then in this scenario, let's say it didn't work, you would do CPR and then do it again. So perfect job. Okay. Scenario 4. An ambulance, in this case you, gets called to a house where an adult is having a partial seizure. Any guesses on why it's important to get there really fast when it's a partial seizure? Davina, do you want to call out? Because I'm looking at the chat again.
Yes, I'm just going to call on someone new that hasn't participated yet. So Mara.
It can progress into a full seizure.
Yeah, that is the main reason. So I'm seeing some answers in the chat like brain damage, unconsciousness, more damage, lack of oxygen in the brain. So a lot of these are symptom related things. But yeah, it can lead to a full seizure, which is also sometimes known as a grand mal seizure. But yes, a partial seizure can go from something that is maybe not so bad. It's not the end of the world. It has minimal potential damage. And if it gets upgraded into a grand mal seizure, or a full one, it can cause a lot more damage. So I know we skimmed over seizures pretty quick because we had a lot of information to go over, but does anyone remember what treatment they can provide for a seizure and in what order they should do so? If you want to guess, that's totally fine too, because I know we covered seizures pretty quickly. Okay, on my screen, I see Vardhan first.
Make sure that their airway is protected and open so that they remain breathing.
Yep, that's a good one. That's a good thing to do, definitely. I'm going to look at the chat, see some other ones. I see a lot of people saying recovery position. Yes, but this would be after the seizure. I'm talking about during the seizure. What would do? Okay, I'll let someone else take a stab at it. Adam, do you want to quickly take another guess at it?
Aspirin is really important when it comes to seizures. I'd also recommend tilting their chin upwards and also like tilting them to the side just in case if their mouth is foaming, you don't want them to choke on the foam. Other than that, an aspirin will only make do.
Okay. That is a good answer. What I'm gonna tell you guys is a little scary too, but if you're ever working on an ambulance and someone is having a grand mal seizure, you do not want to try and give them an aspirin until after it calms down. The reason for that is because they might bite your finger off. I know a few people that have been pretty bad. I don't know anyone who's lost a finger, but when you're having a seizure, because you can be spasming around, they will bite your finger off unintentionally. So do be careful with that. It is much safer to try and just hold their head in position from the side if possible, or hold it to the side if they're vomiting. But you definitely want to avoid avoid putting your hands in their actual mouth. The other thing I did see someone say is keep them away from other sharp objects. That is 100% correct. The first thing that you would do when you check the scene and you see someone with a full seizure is try and move as many things that could cause them harm away from them so that they can't cause harm to themselves just spasming around. So some great guesses. Here are some of the things that you can do in the order. So, like I said, first thing, move any nearby objects, especially sharp ones, away. Yeah, aspirin is for heart attack. It can be for seizure as well, but only for ischemic seizures. Sometimes they're used. For hemorrhagic, where they're bleeding, you would not want to use that. And so normally aspirin is given at the hospital once they figured out which one it is, not in the field. Suction up anything in the mouth and make sure the airway is clean. So like we saw before, the suction tool that, or at least that I worked with on the ambulance, kind of has a long straw. So that way you don't actually have to put your fingers in the mouth. You can kind of just suction from away. So if possible, you can do that if they're throwing up. That way you can do the ABCs. And then, if possible, get an oxygen mask on them. Again, very much so. The first thing and the second thing are kind of the only two things that you definitely can do most of the time. And then once they stop spasming, put them in the recovery position, and try and get them to the hospital as much as possible. It can be scary moving seizures right away because in transit they might have a second seizure. So typically what would happen is you'd move them directly from recovery position into the ambulance and try and give as much treatment in the ambulance that you can before driving, unless the hospital is extremely close, just to prevent, because you don't want someone seizing while you're driving and then potentially getting knocked around in the ambulance, because it's hard to keep them constrained. And then after they stop spasming, you put them in recovery position, check blood pressure, check ABCs. Anytime someone goes unconscious, it's always good to also check blood sugar if possible. Okay, and then our last scenario for today, before we
Sorry
get
to
to our
interrupt, just
shadowing
one small
session.
question.
Yeah,
Just one very small
what's up?
question. Should it indicate that just like it's the initial phase of a seizure, should we just give them aspirin as it's like a very available and like common medication? And it's usually like the only thing available until an EMT arrives. So should we just like give it in all cases? Or will it like actually like hurt a patient if they weren't having a certain type of seizure?
It could severely hurt a patient if they're having a hemorrhagic seizure. So I would not give aspirin if you're just a bystander, unless you are familiar enough with someone to know that they are, like, let's say they have epilepsy, and so you know the kind of seizure ahead of time. I definitely wouldn't recommend it because if it is a hemorrhagic seizure, um, it could cause a lot of harm. It could cause them to bleed out.
Okay, thanks.
Okay, so last, we'll quickly go through this. I'm just going to look at the chat for this because we're running out of time. We have like 1 minute. So an ambulance, this is you again, gets called to a school where a child is having trouble breathing. Right off the bat, a lot of situations to be possible. What do you guys think some would be? Panic attack, asthma, choking, edema, allergy. Okay, I'm seeing lots of great answers. These are all potential answers. Let's see, let's get some more information. So you guys have said most of these. COPD is also possible, although very unlikely in a child because their lungs should be very healthy. Um, when you arrive, the initial assessment is increased heart rate, fatigue, and swollen lips. What information here has given you to kind of guide yourself to one potential diagnosis or maybe two potential diagnoses? All right, awesome. I'm seeing many people say allergies, swollen lips. Exactly. So if you're still not sure and you're just suspicious, removing the child's shirt reveals rashes and hives. Does anyone think this might be something different besides allergy at this point? I'm seeing lots of allergy, anaphylaxis, airway construction. Yeah, okay. We're all on the same page. So anaphylactic shock, allergy, because of allergies is what's happening in this case, and then what treatment should be done. Yeah, I'm seeing everyone's got the right answer. EpiPen, EpiPen away. So EpiPen and then rush to the hospital. The EpiPens they'll only last for so long, and then the allergy can represent itself. Allergies also, when they're this bad, can also present themselves a couple hours later. So it's really good to get to the hospital as soon as possible if you have to use an EpiPen. And then yes, like Selena said, EpiPen to the outer leg. All right, guys. That's all for our practice scenarios for today and our emergency medicine workshop. Thank you guys so much for listening to me and staying engaged. We're gonna go to our shadowing with Austin in a second. If anyone has emergency medicine related questions or EMT related questions, please message me on Slack. I really loved being an EMT when I was it. I hope I can do it again at some point, and I'm happy to talk about it because it's super fun to talk about.
Amazing. Thank you so much. So we'll give Rourke a little quick virtual round of applause on Zoom. And what I'll do now is I'm just going to disable the chat for a second so that my message doesn't get lost. But I'm going to send out the first attendance form. So all you have to do is fill this out. If you can't fill it out, in extreme circumstances, it's okay. We'll see that you're on Zoom anyways because Zoom automatically logs you being here. So just fill out the form quickly. We'll have another one at the end of the session as well. But again, thank you so much to Rourke for leading our session today, and we'll have the slides posted in Slack right after the session is over. So I'll give everyone a second to fill out the attendance form. If you want to grab some water, take a quick little break, feel free. And then we'll get started on our guest speaker shadowing in just a few minutes. Also, I actually think this is the most amount of people I've ever seen with like their cameras on in the 6 years that I've run the summer program and all of the winter camps. So it's lovely to see all of you. Did you have a question, Perla?
Yeah, I wanted to ask if Roark counts as a speaker because there's a question about it.
Yeah.
Okay, thank you.
No worries. Dorcas?
I know that like we said the EpiPen would like I know that we said sorry I know that we said to like use aspirin it would be for more like a heart attack situation. So would that be when it would be like put under the tongue, right? Just so like the nerves it can get like through much more quicker and then it can actually like work faster. Like that would be like the way it would be like used, I guess, right?
I think in an ideal world, yes, but some people might only have like the liquid gel aspirin or like the other tablets,
Okay.
and then those you can only swallow. So it just depends
Okay.
on what you have. Normally, in the ambulances, we have like chewable aspirin, so you'll get someone to chew it and then put it under their tongue, and it'll just dissolve really quick.
Okay, perfect. Thank you.
Okay, awesome. So if anyone has any extra questions about the workshop, you can feel free to message work on Slack afterwards. But I think our guest speaker is here. So Austin, who's our guest speaker for today, and he is working at Houston Methodist Hospital, I believe. And he actually spoke during our very first summer program back in 2020. So there were like 100 people there, and now we have like almost 400 people in two programs. So he's witnessed a lot of our growth here, and we're very, very excited to have him back. And he always delivers really fantastic talks. So we're very excited that he's made time for us as well today. So Austin, feel free to get started.
Yeah, thanks, Davina. Happy to be here and be back for another MedStem powered summer program. Like Davina said, I think it's been great to kind of see how much growth this program has had and have a bunch of fun, new innovative stuff to share today. Sorry, everyone, for the mix up with the workshop, running a little late from surgery, but excited to have this talk. And I also have one of my colleagues, Dr. Alex Bauer. He should be on too. He's a CEO. Are you there, Alex?
Yeah, I am.
Perfect. So Alex is one of the, he's the CEO and co-founder of one of the innovative orthopedic companies that I'm collaborating with him on as one of the division managers. So we're excited to kind of share and spearhead this project with all of you all today. And I think you guys will be really excited to hear about it. But I'm going to go ahead and start sharing my slides. And can you all see my screen? Perfect. And Alex will chime in too. He just graduated medical school as well, so he has a really good perspective on a lot of different things and orthopedics as well. So I think this is going to be an amazing talk for everybody, and we will be take so many questions at the end. I know you all always have really great questions, and so we'll start with a big overview. I think I do want to highlight a bit about pre-med and med school, and then go into orthopedics. I know that many of y'all are coming from different backgrounds, different training, some traditional, some non-traditional, some are in high school, some in college, some in med school, some beyond. So I want to capture as much of an audience as possible. And then, of course, my passion is in orthopedics, so I'll spend some time talking about that as well. So a little bit about me, I grew up in Chicago, Illinois. I went to University of Illinois, Chicago. Class of 2019 was when I graduated undergrad. Went straight to med school, staying in Chicago at UI Chicago College of Medicine. And then now, like Davina mentioned, I'm at Houston Methodist down in the medical center in Houston. And I'll be graduating my residency in 3 years in 2028. So Chicago is where I'm from. Now I'm at Houston Methodist, so it's in the largest med center in the country. So a lot of great opportunity here down in Houston. I love playing sports, basketball, traveling. That was a picture of me in Sweden, and then playing golf with friends and family and my co-residents. So outside of all those things, I do like to also make some YouTube videos here and there. It's been a big hiatus because of how busy residency has been, and we've been working on so many other collaborative projects, but I think at least from the high school, college, and med school kind of standpoint, I've made a lot of videos on that stuff, and just starting to work more on the orthopedic stuff as I get a little bit more experience, and working with people like Alex has been helpful to do that.
Okay, so my name's Alex, and I'm originally from Sacramento, in California. I went to undergrad at Chapman University and graduated in 2021. I also went straight into med school at Liberty University, which is an osteopathic school. I graduated this May, Not starting residency this month. I'm doing a year of research and focusing on my business. And so then I'm going to be applying this cycle for residency. I got married during med school between third and fourth year. I'm a big sports fan. I also enjoy cooking when I have free time. And then I founded my Ortho Solutions, where Snap Ortho is a big project that I'm working on. And then there's just some pictures throughout the years, but yeah, that's a little bit about me. And
Like
those are
that.
my yeah,
Looks good.
yeah. And that's the book. I wrote a book about from pre-med till your third year in med school. It really walks you through every step of my journey and some advice I gave throughout there. So
Awesome. Thanks for sharing, Alex. I think that's great. Definitely getting a copy of that book soon. So I think everyone, when you're thinking about what you want to do in life, right, you got to consider what's your why in medicine, right? I'm sure you've heard from really good speakers already earlier today. I think, High Guru Prep gave a good talk about, why medicine earlier. But it's a long journey. I think you really have to enjoy the process because you do go through a lot of ups and downs, like with anything in life, but anything worth it is going to be a bit of a struggle at times. But find out why you want to go into this field. There's so many other great professions. There's other professions in STEM besides medicine. So it doesn't always have to be about going into medical school. So I wanted to kind of start by saying, enjoy the process, ask a lot of questions, be inquisitive, but don't be afraid to check out other avenues too. There are a lot of really great careers out there. Neither of my parents are doctors, neither of my siblings are doctors. They went into other fields and had a lot of success. So there are a lot of different pathways in life. So applying to med school, looking at a bit of the statistics, this might be a little bit outdated, but what I can tell you is the trend is always going up because people are getting smarter. There's more resources out there. There's a lot of different ways for people to study nowadays, whether it's Anki, AI now, so much more innovation. But at least in 2023 for allopathic med schools, the MCAT mean is about a 511, GPA mean 3.75, and science GPA just slightly below that, 3.68, but the non-science was 3.84. So the programs do like to look at this from a different perspective. They look at science GPA and non-science. So I think for all of y'all applying to med school, it's important to know that you can't just, pat your GPA by taking like cooking classes or easy things. Like they also want to make sure that you're excelling in your science classes, particularly. And in general, the acceptance rate is quite low for med school, about 36%. So about a third of students get in. That's sort of based on first cycle statistics. So you're actually in the majority if you don't get in your first time. So not something to, discourage you all. I just think that if you really want this, it's worth it to keep trying and to kind of get in the ballpark and apply broadly. And, I think we have amazing perspective today because both myself and Alex are here. So, you can hear a little bit and ask questions later about like allopathic versus osteopathic. I think both are great. And nowadays things are so competitive. I think applying to both types of programs gives you a really good chance of getting in, better than if you just apply to one or the other. And so, after you apply, you get into medical school. Medical school is going to be 4 years. There's different sets of exams that you take. USMLE and COMLEX. If you're an osteopathic program, that's another type of exam that you'll take. After that, you apply into different residencies. And so, of course, Alex and we're going to orthopedic surgery. I'm going on year 3. Alex is in a research year going into this next year. But orthopedic surgery is a 5-year track. And after 5 years of residency, which, seems like a long time, but most surgical specialties are at minimum 5 years. And then you do a 1-year fellowship so you can focus on spine, sports, foot and ankle, hand, oncology, pediatrics, shoulder, elbow, or joints. And that's something that you'll do sort of for the rest of your career. And so then just to kind of take a level further, once you're applying into residency, orthopedic has about a 60% match rate, and that's typically including both the MD and the DO match statistics. And there's a variety of things they look at when it comes down to this. So both your board scores, which Obviously, you know, these scores are always important at every stage of life. So MCATs, step 1, step 2, step 3. They look at research. And so this is something, again, they'll look at when you're applying to residency. So it's not just something that you're doing to get into med school and undergrad, but it's something you do in med school to get into residency, something you continue to do in residency to get into the next fellowship. So it's really good for all of you all in the pre-med stage to learn research and get into a good swing of it, because it's something that you'll do for the rest of your career. Other things that are important that may be out of the scope of this talk are your clinical grades and your away rotation. So a lot of medical students do away auditions before they start a residency, and that just allows them to have more exposure to a program and get to know the people there better. So where to start? I think, you know, for all of y'all, whether you're in high school or college, number one thing is first starting with like shadowing. I think it's good to understand, you know, what you're getting into. You know, a doctor once told me that like, you don't know you want to be a doctor until you've interacted a lot with patients, that you've smelt patients, and you know what it's like to be in that environment. So shadowing, I think, is great early exposure, something that you can do right away in high school and early on in college if you haven't really thought about this yet. The only thing about shadowing is it's a passive thing. So what I encourage students is that you shouldn't really shadow your whole time in college before med school. It's a good thing to do early on to kind of get an idea of like, do I want to go into medicine? But it's very passive. And when you're writing about it in essays, talking about it in interviews, it doesn't really come off that impactful as opposed to doing something more active. So volunteering in a hospital or volunteering or helping enroll patients in a research study, or any type of volunteering that's related to healthcare or medicine, whether it's like helping people, you know, draw blood or helping with the blood drive or starting a fundraiser or something. Those are things that show different qualities, leadership traits. It also shows that you're doing something to impact patients versus when you're shadowing, you're literally just a shadow. You're standing there watching someone else do their job. When you're volunteering, you're actually there with patients, and you can talk about that in essays and interviews, how you were able to impact patients through, you know, helping bring them warm pillows or blankets or wheeling patients from one area of the hospital to another. So that's sort of the clinical opportunities I think are relevant for people at the stage where they haven't started medical school yet. Other things I would say is, you know, explore different experiences. You know, don't just be someone that does it for the resume per se. Like, you want to just do things that you're interested in. That is what most people will be drawn to when you're doing your interviews. They want to ask you what you actually did, you know, what you're passionate about, things that you enjoy, and they can definitely tell when you're faking it. So really, don't be afraid to step out of your comfort zone. I think try new things when you're in college, when you're pre-med, because really those are the things that stand out when you're applying to both residency and medical school. And that's what they're going to ask you in your interviews. If everyone is doing the same stuff, being a biology major, you know, doing all the same pre-med clubs, but nothing really unique, I think it can be hard to stand out. So that's kind of the, you know, my spiel on exploring different experiences. And then the next big thing is like research, right? Like, I remember being in high school thinking about like, oh, I need to do research, but I didn't really know what it is, right? And so essentially research is like applying the scientific method, and it's used to explore different topics. So actually, if you start research in a project that's actually interesting to you, I think it can be something that's actually very enjoyable. But again, at first it can be kind of daunting. It can be confusing to like, you know, what am I actually doing? Am I doing basic science stuff? Am I doing chart review things? Like, find something that is interesting to you in a different, you know, whatever field of medicine that might be, and then really kind of start from the beginning, kind of work from point A to point B. And number one thing is just to be diligent. You know, Rome wasn't built in a day. It takes a lot of time and effort, but seeing the culmination of your research project, this is a project on the bottom right that I presented last year, kind of looking at, you know, I'm interested in spine surgery specifically. So we were looking at applying stereotactic radiation, a specific type of radiation for patients that had metastatic breast cancer to the spine. And so we were comparing the patients that got the radiation to the ones that did not, and the ones that were radiated did better long term. And so I'm more interested in like what clinically is going to help patients do better. And there's so many different research opportunities and studies that you all can can get involved in at your neighboring universities or when you start medical school. Anything to add on this, Alex?
Yeah, I think that something that kind of goes with all of this is mentorship. Something that I really like about shadowing is while it's passive, it's a really good first step to get connected with a physician who may have more connections. I think that a lot of these different opportunities, if you put a lot of time in and make good connections with people, that will be really impactful in your entire journey. Same thing with research. It's pretty impossible to do this all on your own, so you just really want to try to find someone that can point you in the right direction. And yeah.
Awesome. So just a short video that I made before for people that might be in a stage where they're like picking out their college schedules and how to, figure out what classes to take. I kind of went through like my entire pre-med schedule from like point A to point B, freshman year, sophomore, junior, senior year. And so this might be helpful for people when they're trying to figure out like what's important to take and what's not important to take and that kind of thing. In terms of study strategy, this has been sort of an area that's dynamic, very innovative, and in a couple of slides, we'll kind of get to what Alex and I have been working on. But studying has really changed a lot because of the technology that we have. It's like really no longer pen and paper. You go to college, sure, you might start taking notes on pen and paper because you did it in high school. It's a little bit more independent. You take a lot of exams and quizzes, but for the most part, there's like study guides and there are things that are passed down from class to class. And so while it's more independent, it's not quite the same as medical school where it's almost completely self-independent, where you're studying everything almost on your own. A lot of people don't even go to class. They're just watching lectures online. And this big icon here is Anki, which has become sort of such an amazing way for people to study both in pre-med, in med school and beyond. I use it every day, even in residency. So I think when you get to the point of like finding that work-life balance and how you can like prioritize and compartmentalize your studying, having a tool that uses spaced repetition really helps because it basically tells you based on the human memory curve, like what you actually need to review every day right before you forget it. And it allows you to study a wide variety of information in a relatively condensed period of time because you're not focusing on like, where is that page of that notebook or where is that thing I wrote down? You're not like rereading the notes you wrote. That's chicken scratch like every night. It's actually something that's like integrated into your study schedule where you do your reviews and then you can add new cards slowly every day. And I think it's really revolutionized how people are crushing the MCAT. So there's a miles down deck that I've recommended for students in the past that have been really helpful. And then there's an on-king deck that's sort of the gold standard for your USMLE complex type exams. And then we're kind of developing some new things specifically for orthopedic surgery, which I think would be great for all of y'all to just get early exposure into a field like orthopedics because there needs to be more diversity, more exposure to it because it's unfortunately less than 1% of what you study in medical school. So if you don't know you're interested in fixing bones and fractures and musculoskeletal work, it can be daunting to choose that. And it might be too late sometimes in medical school. So we're trying to really increase exposure to that. A lot of different videos on using Anki that you can find on YouTube, not just from me. There are a lot of other people that have made these that you can find what works for you. And I think just, again, broad advice, and I've already kind of, said this before, but, be open, explore different options. There's so many different opportunities in the world, in life. Medicine has a lot of great benefits, but there's also a lot of costs, opportunity costs for all the schooling, the price of schooling, loans, paying for school, how that kind of affects you. And then, I think the most important thing if you decide to do medicine is always start early. Like Alex said, like having a mentor guide you through this has been probably, paramount to both of our success so far. So when you first get to college, like don't try to do it all by yourself, really sit down, there's pre-med major advisors and people that can really help you get your schedule aligned and help you kind of every step of the way. And here are more videos on that process. Like I said, I've sort of made tips on every kind of step as you go through applications and interviews and personal statements and all that stuff. So kind of transitioning gears now to like why I chose orthopedic surgery. I think it's very unique. Some people will ask sometimes like, what is orthopedics? Is that like working on teeth? Is that braces? Of course, no, it's type 1 collagen, similar to teeth, but it's basically everything from the cervical spine down to the toes of the feet. And it's fixing broken bones or ligament tears, tendon injuries, musculoskeletal injuries, nerve compression, arthritis, so bone on bone. And what I like the most is that there's a start, a middle, and an end. So when we go through some of the Snap Ortho content, as well as kind of go over a little bit about the field of orthopedics, you'll be able to see, what I mean by a start, middle, and an end. I think a real life example that many people can probably relate to is like, a high school or college level athlete that's a basketball player tears his ACL. That's his start, right? He has an ACL tear. We fix the ACL tear, we do a reconstruction, we put a new ACL in, and we see them progress, get through physical therapy, they're re-strengthening their leg. We do usually a physical therapy test where we compare the leg we operate on and their other leg. And usually when it's over 90%, some people even get like 103%, meaning that the side we did surgery on ends up being stronger than the side with their native ACL because they've done so much quad strengthening and hamstring strengthening and rehab. So that's their middle, and their end is when they get to go back to playing basketball, return to sport, and you don't really need to follow or see them again until they have another problem or injury. So it's one of those unique fields where you really get to see a patient full circle from A, B to C, versus some other chronic conditions like working in the ICU, cardiology, pulmonology. You're never really curing someone's like heart failure or congestive conditions. Like those are mostly chronic, and you're helping them manage their symptoms to get through their daily life. But I think orthopedics is one of those fields where you can really, and I'm a little biased, but really impact someone's quality of life and actually fix their problem. Like you see a fracture, plates and screws, you fix it, it heals, and they go on live their life as if they've never had a problem again. And I think that's something that makes it very fun. It's hands-on. It's objective in that way. You have x-rays, MRIs, imaging to prove the work that you did. You can also prove the injury that they have, so you know exactly what you're treating. And, to me, it's fun, and it's great to see patients do well. So just another kind of segue, a company that I work with, I started is called Med School Partners, LLC. We probably have twice as many people than what I have on the slide now, but we're a large organization that work with students that help tutor both the MCAT, USMLE Step 1, 2, and 3, as well as shelf exams and many things that you might go on to face when you get to med school or even when you're applying to med school with MCAT. So if anyone ever has any questions, I'll include information later in an end slide, but you can always meet with a tutor, and I think it's always helpful sometimes to get an extra helping hand. That's why we call it Med School Partners, because we don't really see it as like, I'm the tutor and you're the tutee, but more like we're colleagues, we're both in medicine, like how can we help each other out? We really see it as a partnership. So I think with no further ado, I'm going to kind of hand it over to Alex now to kind of go over Snap Ortho, what we're doing, the innovation behind it, and just let me know when you need me to advance the slides, Alex.
Yeah, of course. So he touched on it before, but why I created Snap Ortho was there's such a huge learning curve when you start to specialize in orthopedics during medical school. And it can be daunting as a fourth year medical student trying to learn everything quickly to really excel on those rotations that he was talking about. And so our app that we've created is an all-in-one orthopedic learning tool. We really try to target the medical student because there are some resources out there for orthopedics, but they're more tailored to residents, and that can be very overwhelming, especially early on your orthopedic journey. And so it focuses on high yield and easy to use resource. Next slide. So we have three different really categories or tools within the app. And so our practice feature was designed pretty much off of Anki, but Anki can be hard to use mobile. You can use it on your phone and whatnot, but we designed practice mode specifically to improve on fracture conference, which is a big piece of orthopedics. Whenever anyone has a big trauma, usually there'll be a conference at residencies, and sometimes the students will be asked to read images. So it's a really important skill as a medical student to learn. And so if you use this, you read the X-ray, identify the classification, and then you can determine treatment. Thanks. So our next feature is Learn, which is really fun. It's been a blast designing with Austin, and we've taken visual learning with the method of Loki, which is kind of like spatial memory, and it helps memorize things really efficiently. And we are starting with trauma, and so our first Learn video focuses on distal radius fractures and all the little details about managing a distal radius fracture. And so it's really concise. They're about less than 5-minute videos, and you should have a really good understanding how to manage these fractures after. And then something really new that has been fun in the last like week or two is Brobot. It's basically an AI tool that can help you prepare for cases. So in your guys' scenario, if you were shadowing a doctor and maybe you were getting an opportunity to go into the OR, you would put what case you're going to go see, and it will give you high yield questions and answers to study beforehand for that case. Yeah.
Yeah, I think this is actually pretty amazing because it uses a lot of the new enabling technologies and innovative things that y'all are probably super good at. And so machine learning, artificial intelligence, really curating all the highest yield orthopedic resources so that even if you know nothing about a surgery, like you can actually get all the pimp questions or all the basic things that you should know before going into a case. And it very quickly kind of gets to that information. So it's something that's going to be incorporated both it's already in the app that we have and the online website, so you can start using it right away. So just as a fun, sort of exercise, we're going to kind of go over a little bit of, basic anatomy just to give you guys a little bit more exposure to orthopedic surgery. So this is a picture of a hip. Yours is not colorful like this, but this is just for design. But the hip has many different regions that are important. And we'll go over that because it kind of dictates the treatment of these based on the location of fracture or injury. So of course you have your femoral head, and you don't have the acetabulum, which is the socket where the femur goes into in this diagram. But of course there's usually a socket where the femur goes into. And so if you look at the head, there's different regions to where something can break. So there's the subcapital region right underneath the head, transcervical, and then basicervical. Then you get to the trochanteric region. So the trochanteric region is sort of here between the greater trochanter and the lesser trochanter. So that's sort of this space here. And so you can have fractures that occur at the subcapital, transcervical, basicervical. Those are all femoral neck fractures. And you can also have fractures that occur between the two areas here called intertrochanteric fractures. And then peritroch is sort of just around the troch, but when you're less or greater than 5 centimeters below the lesser troch, it's called a subtroch fracture. And so there are a lot of different ways to break this, and depending on location and the severity, that would determine your treatment options for it. Okay, I need to clear that off. One second. Okay, so Alex, do you want to go over guarding classification?
Yeah, so the Garden classification is what we use for femoral neck fractures. And it's a good classification because it does help dictate treatment. There's a lot of classifications within orthopedics, and so this is one that probably is good to know. So if you have stage 1, it's an incomplete and non-displaced fracture. And so it's not going all the way through the neck. And so that's the hallmark feature there. And usually it's valgus impacted, which is a little advanced, but that's just the way the force is. So then we move on to stage 2, and it goes all the way through the neck, and it's not displaced. And then for stage 3, it's also complete. So it's kind of like just graduating as you get more severe, and it's incompletely displaced, part maybe a little bit displaced. And then stage 4 is a complete fracture that is completely displaced. And that's clear in that diagram there.
Yeah, I think the stage 3, this picture needs the head to be like kind of like this. Like it's kind of needs to be partially off, but not like fully off like a stage 4. But just keep this in mind. We'll have some questions that we'll want to ask you all. Make sure you're paying attention. So stage 1, incomplete, non-displaced. Stage 2, complete fracture goes all the way across, but it's not shifted at all. Stage 3 also goes all the way across, but it's shifted a little bit, like partially displaced, but not as bad as stage 4 when it's completely off. So like the ice cream kind of fell off the cone. Diagnosing and treating. Does anyone want to give this one a shot? Like, what do y'all think? How would you read this x-ray? And this is something that Snap Ortho would kind of help you all too with if you're interested in orthopedics, but this is kind of use the Garden classification if you can, but also just kind of tell us what does this look like to you? Adam, I think I see a hand up.
I think that is like stage 3, as it's
Yeah.
not fully displaced.
Yeah, that's a great guess there. I think you're definitely right. The fracture is complete, and I would agree with you. It's definitely displaced. So definitely a stage 3 or 4. Whether it's partially displaced or completely displaced, I think can be up for discussion. Jana, do you have anything to add? Sorry if I mispronounced your name.
Yeah, I think it's just a partial fracture, I think.
And then
As Adam said, it's the third one.
yes. And so I think, it is a little nuanced, but you guys are right. So it's definitely displaced and it's complete. Whether it's a 3 or a 4, I think it can be debated. I would probably call this a 4. I think it's pretty completely displaced. It might be subtle if you haven't looked at a lot of x-rays, but the amount of lesser trochanter that we're seeing here, it should really be more like this. So you can tell that this femur is actually pretty externally rotated. So that can really tell you that the profile is almost basically to the point where it's completely displaced and shifted way out. Regardless, a stage 3 and a stage 4, the goal of this is to show you that these are treated with either a hemi or total hip replacement. The nuances of that is essentially a total is when you replace the cup as well. And then a hemi is when you just place a new femoral head into the femur, but you don't replace the acetabulum, which is the cup component. So it might be hard, and even junior residents struggle with this, but this is a hemi, so there's no acetabular cup here. This is just the big head that goes into the native socket. But regardless, stage 3s and 4s, when it's displaced, you're not going to be able to fix it because it's shifted, right? So you just need to replace the entire joint itself with a hip replacement. I think we have a question. If whoever's hand is raised, just go ahead and ask it.
So my question is that if you are like in the garden stage number 1, does the bones work like a normal bone? Does it regenerate itself?
One more time. Sorry.
If you are like in the garden stage number 1, just a little fracture, does the bones regenerate itself? Does it gum itself by itself? Or do you need medical intervention?
Yeah, it's a great question. So stage 1, grade 1 garden would be, like you said, incomplete, small fracture, not displaced. So some would argue if you were very, very sick and you couldn't get a surgery, if you just stayed in bed and didn't move, which is sort of a poor lifestyle. But if you do that for many months, in theory, the bones will heal on its own and you will be able to get back to doing normal things. But we'll go over that in the next slide. But generally, for stage 1 and stage 2, even though they're non-displaced or they're incomplete fractures for grade 1, we still treat them with surgery because it allows the patients to get mobilizing faster and have a better recovery and a quicker return to sport or return to doing whatever they want to do. So we still treat it with surgery. But basically what we would do is we put some screws to hold it in place and then allow the bone to heal. Because if you don't put any fixation or hardware, while it might heal, you'd have to stay in one spot and not walk for months for it to heal. Because if you start walking on it and it's incomplete, you could create a complete fracture and cause it to shift, and then you'll end up with a worse problem. Janari, you have a question?
So with that, like, would you need to do PT or anything like that?
Yes, both treatment options, and we'll go into the other one in a little bit. But if you have a hip replacement, you usually do physical therapy in the hospital. Most patients that get a hip replacement electively, so maybe you have family members that have hip arthritis or knee arthritis, they get a joint replaced, they usually go home the same day and they're walking and they're really happy. Unfortunately, patients that have these hip fractures that we're kind of studying here today, they don't show up to your office with a hip fracture and say, I want a hip replacement. They're usually admitted in the hospital because unfortunately they had a fall or some traumatic injury that caused this. So they're already admitted into the hospital. They get their hip replaced, and then they usually work with therapy for a few days until they're up and walking. And then after that, if they need more help, they can do physical therapy outpatient at home or home health. But most people, they're up and walking with therapy. They're able to go home and not have to do anymore. So, Alex, you can go ahead and lead the next case we have.
Okay. Does anyone want to take a stab at this one? I see some people in the chat are going and saying stage 1. Does anyone want to try to read the x-ray, what you see, or explain where you see the fracture?
Just to make it easier, this is a left hip, and I think Camilla's hand was raised. If you want to give
Okay.
that a
Camilla?
try. I think you're muted. You could try someone else. Why don't you pick someone
Hello?
else? Oops. How about
Anyone?
Nora? Yeah, anyone.
Garden stage 2.
Okay. Good guess.
I think that one thing that our app has is this page on how to read x-rays too that you guys can check out after this. A big thing with reading x-rays is you just want to start with kind of the obvious, and for this you would start with whatever side. So he told you it was the left, and then you say a view which could be a little bit advanced, but this is an AP view of the left hip, and then you can, even if you don't know anything, you can just say like a hip fracture, which is true, and maybe there would be follow-up questions after that of what classification do you think it is? And so everyone in the chat is saying stage 1 or 2, which is definitely correct. It's not displaced. For here, it's fairly difficult to see a fracture line that goes all the way through. I would probably lean towards 1. What do you think, Austin?
Yeah, this is a 1. So kind of Alex alluded to it earlier, but this one is actually like valgus impacted. And so kind of the easiest way to tell is like you can see that the cortex here medially is well maintained. So there's nothing breaking there. So it doesn't go all the way across. But if you look at this sort of area here, it's going into valgus, which is probably confusing for some of y'all, and it was confusing for me too when I first started residency. But essentially, you know, if you have, let's say, like this is your knee and this is your feet like this. Valgus is whenever it's going out this way, and varus is when it's going in like this. So the way you remember this is like valgus is like, think about like gum, think about like the knees getting stuck together. So valgus is always like the distal extremities going out lateral, and then varus is the opposite. So varus would be more like this, where the knees are here and the feet are here, but the distal part, like the feet or the leg, is going more inward. So that's sort of a lot, I think, to process and probably out of the scope of this conversation. But if you kind of look at this and think about what this would normally look like, this femoral head, this femur shaft is sort of going out more into valgus, which is what's causing this impaction here. So a normal femoral head might look like this, and the one here looks more like this because it's impacted here. So it's going out lateral. So it's more in valgus. Either way, I think what the most important thing about getting out of this is that it's either stage 1 or stage 2. Since it's valgus impacted, it is a stage 1 Garden classification. And regardless, since these ones are non-displaced, the most important thing is stage 3 and stage 4 are displaced, and 1 and 2s are non-displaced. So when they're non-displaced, you can actually fix them with their closed reduction percutaneous pinning, where you actually put K-wires, like you put wires through to hold it in place, and then you can thread a partially cannulated screw into the K-wire and then take the wire out and fix the fracture this way. This is a bit advanced, but like, does anyone want to guess why there are threads on the screws here, but like there's no threads back here? Like, why is part of the screw smooth and part of the screw have threads? It's a good thought exercise, I think. And I think Adam here is the first one to raise their hand.
I guess it's to prevent like the movement or the dislocation of the threads and to keep them in place.
Good. That's a good guess.
So I have a small question
Yes,
regarding
go
the
ahead.
hip. Are there any cases of like lead poisoning or any of like the metal leaking into like one's blood? Or are these only in like cheaper types of replacements? Because I heard a lot about cases where patients got like sick and like faced poisoning or even death from their hip replacements.
So over time, you know, back then in the early 90s, they used to do metal on metal hip replacements. And so you could get metallosis over time where the metal pieces would rub on each other. And that could cause some systemic reactions. I haven't seen many reports of it causing like death, but it can cause some systemic issues. But nowadays, there's no more really metal on metal. Most of the implants are like metal with a ceramic ball with like a polyethylene plastic and then a metal stem. So really it's just a ceramic ball articulating with plastic. And so you don't get as much abnormal reaction. And then definitely haven't seen that with like any screw fixation. Mara, go ahead.
So that it's easier to like take the K wires out and put them back in.
Good question. Good answer. So not necessarily. I think you're kind of getting on the right track, but yeah, the K wires are mostly for us to have an idea of where the screws are going, and then we can thread the screws through the K wires because it's a cannulated system. But let's take one more guess, and then I'll tell you all. Isha, do you want to guess?
I was thinking that it was just being able to like, I don't know, like connect with the bone kind of so that it will be able to move or heal properly. That's all I have.
That's really good. That was like the best answer. Very close. So essentially, it has to do with the fracture healing, right? And so I want you all to think about whenever you're putting screws in the wall or something, right? Like it's somewhat like carpentry. So if you have the fracture here and the head is like here, right? And the rest of the bone is here, you want to compress the fracture together because whenever you have bony healing, right, things are going to heal better if the edges are aligned to each other because that allows for healing, right? So if you had screws that were fully threaded, you would still get this compressive effect, but not as much as if you partially threaded screw. Because since the threads are only biting the bone over here, the smooth part doesn't get any purchase, right? So as you're putting the screw in, the threads are only biting the far aspect here of the head. So the threads are biting this bone, and as you turn the screw in, it actually pulls this piece into the other piece. So essentially, if you look at the X-ray again, whenever we put these screws in, we're actually pulling this fracture piece toward the fracture line, which is here. So that allows for the two bones to come together. And obviously, when you have bony contact, that's going to allow for better bone healing. So that's the reason why we do partially threaded screws. Jana, go ahead. Let's keep going then.
So it's like the bone of the baby when it's still a born. So the fibrous tissue is being fused like this.
I
And
didn't.
also we use this metal made of titanium.
Mm-hmm.
Can you hear me?
Yeah. So, sorry, were you saying if the screws are made of titanium? They're usually titanium or stainless steel. I think you might be muted.
Oh, sorry, I didn't. So it's made up of titanium because it's inert element, so it doesn't react with the bones. In addition, also the fibrous tissue of the baby bone, it's being fused like this, so it's being easy to recover of the fracture of the bones, I guess.
Yes, exactly. It's easier to make more bone because, in theory, like if you have a bone that's here, let me do this. So if you have a bone that is not compressed, like it's like this, it will still try to heal, but what happens is it forms a lot of like fibrous tissue and callus, and it doesn't heal as well as if you have the bones actually touching each other. This is going to be the stronger way for bone to heal. That's sort of just a general
As it's
concept.
the angles between the bones.
Yes, correct.
Thank you.
You're welcome. All right, Alex, I'm going to hand it back to you here. I don't know how to go back on this, unfortunately.
So we just start walking through kind of how you would use the app. So this is the practice feature, and it's pretty much exactly what we just went through. And so here, the reading is all right there, but so this is kind of the very structured way that you would want to read an X-ray. And so I think if you click one more time, I have that page. And so this is something that would be helpful for you to look at after this talk because it goes into kind of the general structure that all pretty much everyone in orthopedics uses to read the X-rays. It's very systematic. You go through the steps, and it's how like physicians dictate and all of that too. And so then after reading the X-ray, the next step would be to classify, which we just did. Does anyone want to say what they think this classification would be? Anyone can go. Yeah, some people in the chat, 3 or 4. Yeah, there's definitely displacement because if you look, the trochanters are not in line at all. Very shortened.
And unrelated, but you can see on the other side, like Alex mentioned on the read, there's a previously well-fixed total hip arthroplasty on the left side. So if you kind of remember that other X-ray I was pointing at, this one you can actually see a screw and a metal cup. So this one's a total hip replacement because the cup and the ball, both the socket and the ball were replaced, which is different than the other X-ray when it was just a ball going into the native socket. So that was a hemiarthroplasty, or a partial hip replacement, they sometimes call it.
Yeah, I'm seeing pretty much everyone in the chat is saying 4, which it would be correct here.
Absolutely. Yeah, this is a 4. So then does anyone know the treatment for that? And you can put it in the chat or shout it out.
Would it be a replacement?
Yes, exactly. Really good. So a matching set, a replacement for the other side. So it's a Garden Type 4. And so this is all in the Snap Ortho app. And you can see at the bottom here, if anyone's used Anki, we use the same algorithm of like, again, hard, good, and easy. And so this is all going to be in spaced repetition for you all. So you get good practice exposure, reading x-rays, and getting more of that orthopedic education early on, which I think would be really helpful for everyone. And so the treatment would be to get total hip. And so the app even goes in to ask you what is a management, which is something we already did. And then it would be a hemi or a total, depending on the patient's risk factors. But regardless, you're replacing the hip. So I'm going to kind of pause on this slide for a little bit and let Alex kind of talk about this a little bit more, but we have pretty much social media on like everything for Snap Ortho. And so I think this is a great app for everyone to have on their phone to really, just get more exposure to orthopedics early on, whether that's pre-med or college, med school, or wherever you're at.
Yep, it's free to use. And we have for the Learn videos, we have accounts that you just sign up, and we're going to be releasing another Learn video here soon. And I'm open to feedback. So on social media, if there's anything that's not working properly, or if you have any just general comments, we're always open to feedback as well. So thanks everyone for downloading it if you are. And then yeah, I see that some people are talking about Android. The Android app is almost done, but we do have a website, and that will have access to all of the robot, the learn videos, and then possibly in the future the practice, but most likely that will roll out with the Android app.
Yeah. So great for shadowing, for anyone's interested in orthopedics, like having some early exposure, using the app, and to kind of go over a little bit more what the Learn videos look like. It's basically Sketchy for orthopedics. So if anyone has used Sketchy, I think it's really an amazing resource to just like digest and learn orthopedic concepts, but will be in a very easy way to digest. So using like cartoons and repetitive symbols, we use like the memory of loci. So like in our sketches, like if we're giving an antibiotic like doxycycline, the doxycycline part, we use like a bike as that bicycle represents doxycycline, which connects to the antibiotic. So every time you see that bike in other sketches, you'll know to give doxycycline. So there's a lot of different connections that we've used and incorporated to make things easy to remember.
Yeah, like we have the garden classification that we just went over today, and each of the different rooms in a house is the type 1, 2, 3, and 4. And so hopefully that will help if you're trying to learn a lot of the different classifications in the future.
And then these are just some extra slides for me. I've given this talk a few times, and so Davina and the MedStem powered people know how to reach me, but Austin Wynn MD pretty much on everything. And for anyone interested in med school partners or just getting any one-on-one tutoring, you'll probably end up talking to me on the phone or my partner. But we have a website, medschoolpartners.com, and so there's a lot of resources for that online too if anyone wants MCAT or step 1 or 2 tutoring. But I think at this point, Alex and I are both willing to stay on and take questions. And y'all always have so many questions. So I feel like having Davina or someone kind of let us know which ones to answer, or having people just ask them out loud. We're happy to do that.
Yeah, absolutely. First, let's give Alex and Austin a huge round of applause on Zoom using our little chat features. The presentation was fantastic, and I'm sure lots of people will be downloading all of the resources and the app that you shared with us. So thank you so much again for coming to speak. I think this is your third time speaking during our third or fourth time speaking during our summer programs. And also what we might do before we jump into the questions, also because some people might be leaving, is we'd like to take a group picture with you and Alex. So if people want to turn their cameras on now, then feel free. We'll take a quick group picture and we'll send it to you afterwards.
Just let us know when to smile.
Yes, we'll do. I'll count down once you're ready. But I will give everyone a second to turn their cameras on if they're not on already, and then we'll go ahead and take a little picture. So I'll give everyone a sec. And then I'm just gonna lower the hands for right now, just so we can take the picture. And then as soon as we're done, you can feel free to raise your hands again. So if you have your hand raised, just lower it for a second, and then you can put it right back up as soon as we're done. Amazing. Thank you so much to everyone. Okay. I'll give everyone like 10 more seconds. I'm gonna have to take a couple because I actually think so many people have their cameras on. It fits on like 3 full-size screens for me. So hold your smiles for like 20 seconds. And then just try to avoid messaging in the chat because if you message in the chat, it'll actually be covering someone's face. Okay. And I'll pin our guest speakers as well so you can see them. Austin, would you mind saying something quickly, and Alex as well, just so you pop up on the first?
Yeah, sure. Sounds good.
Perfect. Thank you. Okay, I'm going to take a couple of pictures now. I'll count down from 3, and then I'm going to take a bunch, so just keep smiling, okay? All right, 3, 2, 1. All right, taking a couple more for those of you on my other screen. Okay, 3, 2, 1. And a couple more. Okay, perfect. I think I've got everyone, so feel free to turn your cameras off now, or you can keep them on if you want to ask questions to our guest speakers. And now if you want to raise your hands, what we'll do, Austin and Alex, is I can either help moderate it so we can do a question in the chat and then also a question from people that have their hands raised and we can go back and forth, or I can just call on people that have their hands raised. It's totally up to the both of you, but I can help facilitate that.
Yeah, thanks, Davina. Sounds great. We're available.
Amazing. Okay, and then I'll put the spotlight back on both of you so people can see you, and feel free at any point if you want to share your screen, that's also totally fine. So, okay, I will get started. And if anyone has to leave now, or if you don't have any questions, you're more than welcome to, as long as you filled out the attendance form, and we'll see you on Wednesday. Okay, so first up I have Hala.
Okay, so I wanted to ask, what if someone have like a hip fracture or stage 4, but it's like too old to have surgery, or their health conditions is not good enough to go in surgery? What should we do?
So I think the question was if someone has stage 3 or 4, but very sick, can't have surgery. That's a great question. We see it not too infrequently. A lot of times patients that have these, they have other medical comorbidities. And so they maybe have a bad heart or have like, really bad disease that they can't undergo general anesthesia for surgery. Unfortunately, the mortality rate for a hip fracture is not treated with surgery. And within 48 hours is like pretty high. I think it's about, 40 to 60%, unfortunately, in that time frame. So they can be, bed bound and not have surgery, but they end up, majority of them, not really making it to much quality of life. And so we do everything we can to get their hips replaced and fixed one way or the other within 48 hours.
Okay, thank you.
Awesome. Okay, so our next question from the chat was, They just wanted to know what your typical day-to-day looks like as someone that is an orthopedic surgery fellow, and do you have a specific or common type of injury that you treat more often?
Yeah, it's a great question. So during my training, I pretty much like spend 8 weeks on every specialty. So right now I'm doing like orthopedic oncology, mostly like big sarcomas. I'm at M.D. Anderson, one of the top cancer centers in the country. And so we see a lot of advanced, Ewing sarcoma, metastatic tumors, bony cancers. And so that's sort of the main thing I'm seeing now. But I was just on hand surgery. And so we saw a lot of like carpal tunnels, wrist fractures, cubital tunnels, trigger fingers. So I think there are a lot of common things you do see in orthopedics. And it just depends on what subspecialty. But since I'm going into spine surgery, I'll be mostly treating like arthritic diseases in the spine, herniated discs, and things like that.
Awesome. Okay. Our next question is from Mahalia.
Hi, can you guys hear me?
Yeah, we can.
Okay, so I have a question with hip fractures. So, I was one day in Bangladesh, I traveled, and there's a lot of high traffic, and unfortunately, I witnessed a car crash. And there was this guy, and I think he had a displaced hip fracture. But the thing is, his like you have the hip, right, and then there's the bone, but it like protruded out of his thigh. So like I was wondering, like, how would you treat that as a surgeon since it's like an open wound almost?
Yeah, that's great. So what it probably sounds like in this common with motor vehicle collisions is a femoral shaft fracture. And so a little bit different than what we were talking about. The hip fractures we were kind of looking at were a little bit higher up. But when you have a femoral shaft fracture, basically the femur breaks right down the middle and your iliopsoas is one of your hip flexors. So usually it pops out and then it pokes through the bone on the front, the anterior part of the thigh. And whenever you have open bone injuries, it's called an open fracture. And actually, Alex, we have a video on open fractures and management of those as well that we're working on for Snap Ortho. But the number one thing that you can do within 3 hours is get them started on antibiotics. If it's within 1 hour or 2 hours, the faster, the better. So as soon as they hit the emergency department and they call me, I tell them to start antibiotics, make sure the patient's up to date on their tetanus. And then you would want to temporarily, just wash it out at the bedside. So getting any gross debris, grass, dirt, anything that is common in a car crash kind of out of there just to make sure it's not as dirty as it is. But those will need to go to the operating room right away for a formal irrigation and debridement. So really washing out and cleaning it out in the operating room. And then typically when they have these fractures, they have other injuries. And so we kind of go into a damage control orthopedic mindset. And so we typically put an external fixator frame. So we'll use some type of either traction or external fixation to kind of hold the bone out to length until we can stabilize the patient's other injuries, their heart, their lungs, life over limb. So making sure that we protect their life first. And then once they're more medically stable, we can put a titanium rod down their femur. And then that will allow us to fix the fracture and get them walking and back to doing what they want to do. And actually, I actually have one here in my office. So this is what that rod looks like. So it's a titanium rod that you basically put down the femur, and then you put screws through it, through these holes that go into the femoral head. And so it's pretty stout, and then they can walk on it as well. So.
Okay, thank you.
Awesome. Okay, I'm gonna take a question from the chat now. And so someone asks, is there a difference between like getting wet or dry lab experience in high school, undergrad? Does it reflect differently on your applications?
You want to take this one, Alex?
Yeah, I mean, I think that the big thing here is what are you interested in? I personally am not a very big basic science person, and I'm more interested in clinical research. And so that's what I started with, and that's what I'm continuing to do now. But by no means, if you like basic science, I think that wet lab is a great experience. You just learn different skills for each avenue. The big thing is that you can just prove like he was saying, Rome wasn't built in a day. You just want to be persistent, and that will go more than the specific experience that you do.
Awesome. Thank you so much. Our next question is from Tari.
Hi, can you guys hear me?
Oh, yes, we can.
Okay, so I was asking, as a high schooler, I wanted to know that, like, how do you go about essentially putting together research and then publishing it? Specifically in terms of research and then what companies would work. Like, how would you go about actually conducting this research?
Alex, do you want to take this since
Yeah.
you're doing research right now?
Yeah, of course. I think that like the biggest thing is finding someone who is active within research. Um, there's also levels of research, and even if you just write kind of like a thesis paper, like that's something I did earlier on in undergrad that then, you get your feet wet a little bit, and you start to know the scientific method and the steps of going about it. Honestly, you just have to kind of take whatever opportunity you can find and then get more comfortable and form connections is the biggest thing with research. Um, just do something that you're interested in, is my biggest advice there.
Okay, thank you so much.
Awesome. Okay, I'm going to take a couple more questions from people that have their hands raised. So Adam's up next.
In the case that you all were like not to get into orthopedic surgery, like matching, what would you have chosen other than orthopedics? Like your second or third option?
Yeah, I think for me, so I switched over to mobile. I gotta have another thing to run to, but I can still answer some questions. I considered, I always knew I wanted to work hands-on, so I always knew like surgery was something I wanted to do. But essentially, I only applied into ortho and was fortunate enough to get it. I considered like ophthalmology, work on the eyes, or ENT, ear, nose, and throat surgery, but at the end of the day, I think ortho was the thing that was most exciting to me. So I would have just continued to try year after year to get into it because it's what I'm the most passionate about.
Okay, yeah, thanks.
Awesome. Okay, up next we have Ramsha.
Hi, I have a question regarding research. And in the beginning of the presentation, you said that we should be looking for and exploring other experiences. Would you like to just let us know what kind of experiences you were talking about apart from like STEM, as well as for the research? As a non-grad med student, upcoming med student, I want to know how can I get into research? I feel like there are a lot of things that you need to do, but there is this thing as well where you are actually just checking off the list. And I am an international student as well, so getting involved in research is kind of out of my scope. We are not allowed to be in research. So what do you want to suggest about that part?
Yeah, I can kind of tackle the first part and then also the research. So for me, I'll just kind of list off what my experiences were. Not all of your experiences that go on your application need to be healthcare related. Obviously, that's what you want the general theme to be, but you also just want to show that you're passionate about other things too. So for me, I played football in college. That was a big part of my application, all the leadership skills that I gained through that and working with my teammates and whatnot. I did EMT as my other big experience in undergrad. I just really liked that. And so you kind of can pick your experience for what's available to you and what you're interested in. In terms of research, I think that kind of it is a very hard question, and I was in your guys' shoes as well. But the biggest thing is if you can just think about who near you is doing research. So, at universities, a lot of the PhD professors also have research going on, and some may be more active than others. And a lot of times you can join a project, just be an extra set of hands, or you could be looking up references. A lot of people are willing to help you because they were in your shoes and realize it's hard to get into. So yeah, going to your university, professors, or then residents, they are working really hard, and a lot of them have research projects, and sometimes they may need help with that or attending. So that's kind of my advice there. You just kind of have to find someone who's doing a lot of research.
Thank you so much for answering that. One last question. If your school doesn't have any pre-med counselors, or how would you get started with it without a counselor?
I think that there are a lot of good resources out there online. I haven't really shot, I'm kind of out of the loop these days, but I think there's a lot of good like podcasts out there, a lot of companies like the med school partners that can offer advice and mentorship. And so I think that maybe that would be a good way to go if your school doesn't have the infrastructure.
Awesome. Thank you. Our
Thank
next
you.
question's from Casey.
Hi, I was just wondering, like, what is the deciding factor whether a spine case goes to neurosurgery or orthopedic surgery?
Yeah,
Yeah,
that,
go ahead, Alex.
yeah, Austin can answer that one.
Yeah, I mean, Alex, I'm sure has the exact same answer, but essentially, when you finish orthopedic residency and do a spine fellowship, it's the same fellowship that neurosurgeons do after they finish a neurosurgery residency and do a spine fellowship. And so they become essentially unanimous. You're a spine surgeon. So anyone that has a spine problem can go to a spine surgeon that has either background in training, just like a hand surgeon can be trained in a 5-year general surgery and a 3-year like hand route, or you can go through hand surgery as a plastic surgeon and then do a hand fellowship, or an orthopedic surgeon do a hand fellowship. So they essentially become an expert in everything regarding the hand. And it's the same thing with the spine. The biggest difference is just that for me, being an orthopedic surgeon trained, I will be still, nailing hip fractures and fixing broken ankles and wrists when I'm on call, which is, I think, a little bit more fun and easier. But neurosurgeons, they have to do more cranial work and also take call for brain related trauma and hemorrhages and brain bleeds. So that may be more time intensive, or just a different type of call. But then they will also be able to do spine cases. So really, it just you can go to any spine surgeon, but just their practice volume when it comes to call might be a little different.
Okay, yeah, that answered my question. Thank you.
No problem.
Okay, we're going to take a couple more questions, and then if we don't get to answer your questions today, either if you have your hand raised or if you've posted it in the chat, what we can do for you, both Alex and Austin, is we have a form where people can submit like extra questions, so we can send that over to you and you can respond to some of them if you want, but there's no pressure to do that. All right, so we have Kiara.
Hello. My question is, how did you guys manage your mental health during medical school or residency, and did you find it difficult to find time for yourself?
So for me, I took my school had a lot of exams. Like the frequency was every week or every other week, and so after every exam, I would like do a hard reset. I wouldn't really do much schoolwork. I'd go outside for walks. I would exercise a lot and kind of reflect. I think that I figured out that I would study when I was in a good mindset, as opposed to just pure quantity of studying. If you're studying and you're in a good study mode, it's a lot more beneficial. And so I cut down on the total studying time as well in med school. But yeah, just like those little hobbies. I mean, for me, it was cooking. I love coffee. And so those are what got me through it.
Yeah, I think incentivizing yourself, like Alex was saying, as you go through every milestone in life, not getting too caught up on like, there's always going to be work to do. There's always a mountain of work, and it doesn't really change, even for me in residency, even more so than medical school. Just so many things that can be done, whether it's like for your patients, for your research, but you just have to be able to prioritize other things that are important to you. So, spending time with my wife, my family, making sure that I really um, prioritize the other things in life and things that I find enjoyable outside of work. I think if you don't start having that work-life balance when you're in medical school, you can't just think that, well, when I get to this next stage, I'll have it, or when I'm in attending, I'll have it. It's really something you should incorporate early on because you're always going to be busy and that's not going to change.
Thank you.
Okay, we'll take a question from Sophia and then we'll wrap up for the day.
Hi, I actually have like two questions. The first one is how do you handle complications or unexpected findings during surgery?
I think the question was about complications, you said, in surgery. Is that right?
Yes.
Yeah.
Yeah, I think honesty is the most important thing. If any surgeon tells you they've never had any complications, they're either a liar or they haven't done enough surgery. And so most of the time, it's just a common part of operating. We're humans, no one's perfect. Minor and major complications, I think the minor ones you don't really know about until a little bit after surgery. So, sometimes a screw can cut out or something may not align the way that you wanted it to, and you may need to do another surgery to fix it. I think just being open and honest with the patients and the counseling that you talk to before surgery, like that pre-operative appointment, I think that's really an important time to go through the common complications and things that can go wrong. And being honest, like in the world of spine surgery, it's very important to tell patients that you know there are major risks. While it's less than 1% of the time, like you can have paralysis from this surgery, even death, like is a real potential option just because of how high risk the structures are that are around the spinal cord and the aorta. Um, you just have to be open and honest with patients, and when it happens, you don't abandon your patients. You're there for them. Like you find a way to help fix the complication. There's always something that can be done, and sometimes just being transparent and navigating that is sort of the best thing that you can do for them.
Thank you. And my other question was, what other ways make someone a competitive applicant for an ortho residency?
I think that the statistics are something that you kind of just have to be aware of. You definitely have to score well on step 2, which is the only scored exam before you apply to residency now. You also have to do well in your clinical rotations. Like he was saying, you get letter of recommendations, which go on your application. And then the last piece is research. So it is very similar to the med school process. But the big thing that he had touched on earlier is those away rotations where you show your face, you show your hard work. That's what really is a big piece of orthopedic match.
Thank you.
Awesome. Thank you so much. Thank you so much to Alex and Austin again for staying back so long to answer lots of our questions. We're going to be sharing their social media, the app information that they shared today, and everything else with you after the session. The recording is also going to be posted on YouTube, so you can access it there. For everyone that didn't get to ask questions, I know tons of you had really amazing questions that you weren't able to ask today just because there's so many of us and our sessions are only 2 hours long. Well, you can submit them to the form and we'll pass them along to them. They might be able to respond to some of them and get back to you. Or you can also follow their social medias and see if they've answered any of those questions on maybe their YouTube videos, the app, or other social media platforms, okay? So there's no homework other than the attendance forms today, so you're all more than welcome to head out now. And thank you so much again to our fantastic guest speakers, and we hope to see you back again Wednesday at the same time for our second session.
Thanks, Davina. Thanks, everybody. Appreciate your time and wishing you all the best. Feel free to reach out to us on any of those platforms. We're happy to help.
Thank you so much.
Yep. Thanks, everyone.